Welcome to the section on clinical chemistry with the geriatric and pediatric patients. First, we're going to cover the geriatric patient and how lab results may vary in a geriatric type of setting. Then we'll cover the pediatric patient and how things may differ with them versus an adult. So let's get started. The impact of the geriatric patients on the clinical laboratory is going to be huge as our baby boomers get older. Right now, our geriatric population is growing in the United States. In the 1900s, it was expected that people would live about 47 years. Now we're figuring that the average person born in 2001 will live to about 77 years. And by 2030, which actually isn't that far away, 71 million people in the United States will be 65 or older. This is going to have a huge impact on healthcare as we're going to need more healthcare providers. We're going to be doing more laboratory testing. And so therefore, that's a good thing for us for jobs, right? We want to make sure that there's plenty of work out there for us. So with the geriatric patients, there's a need that will correspondingly increase as they go up. It's also important to know the term geriatrics, which is the branch of healthcare concerned with the aged. All right, so with geriatric patients, the demand on the healthcare system is different. We need to shift to meet the needs of the chronically ill. So usually once they are diagnosed with a heart issue, they keep that heart issue the rest of their lives. We're going to see more physician office visits as they have more of these issues appear later in life. We're going to see more hospital stays and therefore more laboratory testing. And if you think about it, Medicare was designed to cover 1% of the population, but now it's covering 17%. And even as we move further ahead, it's going to cover an even larger number. So being in the laboratory, you're going to find a lot more managed care going on with physicians only being able to order certain tests for certain diagnoses. So things get pretty particular. This is where medical coders and things become absolutely imperative to make sure that things are being billed correctly so that we get the correct reimbursement back. So when somebody ages, there are some different things that happen in the body to cause them to get older and have more problems. We have intrinsic and extrinsic type of factors. Intrinsic ones are genetic. Those are the ones that you're born with. You get it from your grandparents and your parents. The extrinsic factors are ones from the environment. I always think of the movie Erin Brockovich where she went through all of these all this trouble to interview all these people that were living underneath the electrical wires and getting cancer and such. That would be considered an environmental factor. With that, we see change in the structure and cell damage. So let's take a quick look at all of these theories. I know I have a lot listed on one slide. It's better than having, 5 slides with one thing on each slide. So we're going to kind of just pick apart each one and I'll tell you what's really important to know. So the different theories. The first one is random genetic damage. As you're walking around day-to-day life, there are different mutagens or radiation damage that can occur to your skin or through the things that you're eating or drinking. And this can cause chromosomal translocations and transcriptions and things, which can cause cells to replicate abnormally. The next one is glycation. We've learned in the past about the glycation of the hemoglobin in the hemoglobin A1C. Well, as things are exposed to more and more sugars over time, we end up with a glycated end product, or a sugaring thereof. These modified proteins eventually accumulate and can interfere with both cellular function and structure. So eating that excess sugar is probably not going to help you live any longer. Then we have developmental processes involving the immune and neuroendocrine systems. Our immune system is going to decline with age. We see a thymic atrophy where the T cells are stored and a loss of B cells due to the decreased response to new antigens that you may become in contact with. So it becomes a lot easier to die of things like influenza and other simple infections that the younger people may be able to handle a lot better. Then we have neuroendocrine issues. In postmenopausal women, we have loss of estrogen and therefore loss of bone calcium. They kind of work together. So therefore, they're more apt to, when they fall, break a hip, become more immobile. The more immobile you are, the more likely it is that you are going to fail more quickly when it comes to health. In men, we have a decrease in testosterone level. Testosterone is the build of muscle. You become weaker. When you're weaker, your immune system's going to suffer from that as well. So all in all, this kind of involves a snowballing effect that makes it difficult to stay more healthy as you get older. Then we have just genetic programming. Everybody is programmed by their genes to live a certain number of years. Unfortunately, my great-grandparents have all lived to 98 and 100 years old, so I'm fairly certain I'm going to live to make my children miserable when I'm in a nursing home because of my history, unless, of course, I die in a car accident or something. You do need to know the definition of apoptosis, which is pre-programmed cell death. That is a term that you should be familiar with from hematology. And as we move through some of these PowerPoint slides, you are going to notice that other courses you're taking are going to come into play. We're going to talk about a little bit of immunology, we're going to talk about a little bit of hematology, just to see what happens to somebody as they get older or how they handle things when they're a baby. Okay, the last one, free radical damage. This one kind of goes hand in hand with number one. Free radicals are things that come from things like the electrical lines in the Aaron Brockovich movie, if you've seen that. It could be chemicals that you're eating in your food. I always think of the fat-free foods that have become so popular in the 80s and 90s to try and help everybody lose weight. In fact, a lot of those foods have a lot of chemicals in them. I think we'll see more and more things moving forward that this is causing more free radical damage than we would like to see. So a free radical is actually an atom with unpaired electrons that's highly reactive and can cause changes in your body. Those free radicals attack the sites of increased electron density, like your DNA, your RNA, your protein, cell membranes, things like that. So that's why, you know, they say try and use your sunscreen. That would help with some of those free radicals as well, because it helps not change the DNA of that skin and cause skin cancer. They also damage cellular components and can cause the death of the cell and cause severe damage that way. So in general, just be a little bit familiar with these theories on aging. You may see this on a test. But in general, aging is a complex phenomenon involving biochemical and physiological adjustments. It's associated with a decreased efficiency in adapting to stress, so your body will have a harder time. If you were, here's an example. Let's say you go to a really tough Zumba class at age 25, you're a little sore, right? You're a little sore the next day, maybe that evening. But if you go when you're in your 60s and you try and do that same Zumba class, your body's going to have a harder time adapting to that stress. You're going to be sore longer. The extent and rate of decline in adaptability depends on your hereditary lifestyle and nutrition. So maybe you are 65 and you're able to handle that Zumba class just as well as the 25. Bless your heart, you've been doing it your entire life. You've got great genes behind you and you've been eating fantastically, not eating all those free radical foods. It's associated with the development of several diseases and disorders. So as you get older, you're more likely to get heart disease. You're more likely to get cancers and things. It's difficult to differentiate between age-associated decline and pathological conditions sometimes. Here's an example. You are 65, 70 years old, and you go to the doctor and say, "Oh, I am so tired." The doctor's like, "Well, yeah, you're 70, you're getting old." Where maybe you have a thyroid condition. So sometimes they say, "Well, you're tired because you're old," and they kind of overlook some of those other things that maybe they should be looking for. And the greatest benefit from lab data may come from monitoring individuals' test values over time. So if you have your cholesterol done and your liver enzymes and things like that, every couple of years, it's best for the doctor to keep track of those rather than just doing lab results when you're 75 and you've never had it done your entire life. It's hard to figure out what may be normal for that person over the span of time if they have not had that done before. So we're going to go through kind of quickly because I covered these basically in the last slide where I listed all 5. And this kind of goes through those again, but I'm just going to touch on a few things. All right, we talked about the endocrine function changes, the menopausal women with the estrogen and the bone loss, and the men with the testosterone going down. But we also see some gonadal changes, so in general, not just testosterone, but other hormones as well. We have a decrease of the DHEA, which is one of the muscle building proteins as well, and a decrease of growth hormone. So you're not obviously growing any longer. We see osteoporosis more often. We hear about that quite a bit. We're going to hear about it even more. It's a gradual loss of bone mass due to increased bone resorption, so they're taking bone osteoclasts, are removing calcium from the bone and adding it to the bloodstream. Becomes imperative that you have enough calcium and that you do a lot of weight-bearing activity. This is something that I don't have listed here, but this is the most important thing. If you are putting a lot of stress on your bones, your body's going to do a great job, even if there's not a lot of estrogen there, of adding calcium back in. So just going out and just lifting as much weight as possible. I'm not saying take in the little 1 pound weights. My rule of thumb is, and I love lifting weights, is that if it's lighter than your purse, you're not doing any good. So a lot of us have those really heavy Mishi bags and giant purses these days. You really need to lift something heavier than your purse in order for it to be effective. So get used to lifting heavy things at a younger age, and you can help avoid a lot of this. Very important to have a healthy diet as well. So there you have it. There's my weightlifting thing for the day. Endocrine function changes. The thyroid. It tends to slow down a little bit. We see more hypo and hyperthyroidism. Sometimes it can get a mind of its own and become hyperthyroid. It can go back and forth. It's difficult to determine unless they do some testing. Your pancreas, he decides to get a little tired, okay? And we see increased amounts of tumors. We also see aldosterone and DHEA production decline, and we see more high blood pressure as people age. Diabetes mellitus and insulin resistance become more of a problem as you get older. This is the type 2 diabetes that we learned about in our carbohydrate chapter. It becomes a very common problem among the elderly. About 18.4% of people over the age of 65 usually end up with some type of an insulin issue. Usually the fasting glucose increases 1 to 2 milligrams per deciliter per decade through life, and the renal threshold increases, and the insulin response to glucose is altered. So we end up having being able to tolerate less of it than we did when we were younger. I think all in all, the human body is not meant to handle the amount of sugar that us Americans pour into our bodies. Think about the amount of ice cream and candy, but it's not just that. Things like potatoes and other bread, those fall into that sugar category. The more of that you eat is going to cause some issues in this area as well. So once again, the pancreas gets tired, your cells become insulin resistant, and your glucose gets higher, and that becomes damaging on the body. Remember that glycation we talked about? Renal function. Declines begin after age 30. How many of us are over the age of 30 that are listening to this right now? By age 60, it's reduced to half. So we really need to take care of those kidneys that we have, and because we're only going to have half the function by the time we're 60. We have a gradual loss of nephrons. They just get tired and old. They don't work anymore. There is decreased enzymatic and metabolic activity in those tubular cells. And we see more atherosclerosis as well. There's other diseases that wreak a lot of havoc on those poor kidneys. Think about the type 2 diabetes, having the increased blood sugar. That's not good for your kidneys. What about the atherosclerosis and the increased blood pressure on those kidneys? That's not good for your kidneys either. So we really need to keep an overall health to help save these organs. Some of the tests that we do, little review, we talked about this a couple weeks ago. We can test the urine volume, your BUN, uric acid. We can do a creatinine clearance to see how well these kidneys are functioning. And usually if you can catch it early enough, sometimes you can help reduce the fact that it could get worse if you kept doing what you were doing. We also can see increased dehydration and renal disease as you get older as well. We have a lot of hepatic function changes. This is one that is more apparent than the others, I think. We see atrophy, decreased liver weight, and decline in liver function. We see a decrease in the total protein, albumin, and transferrin because it's not making as much. And we may see a little bit of decline in urea synthesis and bilirubin metabolism. The function of being able to detoxify and metabolize drugs goes down. So this is where your therapeutic drug monitoring becomes imperative, because an 80-year-old is not going to metabolize a toxic drug, well, maybe not, I shouldn't call it a toxic drug, a therapeutic drug, as well as somebody in their 20s may be able to. Then we have some pulmonary function and electrolyte changes. After age 25, the lung, thoracic cage, respiratory muscles, and respiratory centers in the central nervous system change. There's a decline, especially if you're a smoker or you live in an environmentally polluted area. Your lung capacity decreases. I think that a lot of those that are exercising less, that kind of comes into play. Your potassium might start to increase slightly from 60 to 90. Maybe that's due to your cells maybe not living quite as long, so that they tend to pop faster. I don't know. There could be a couple reasons for this. We see respiratory related diseases prevalent, okay, especially the influenza. We may see somebody with the flu, elderly get the flu, and then they get a secondary infection from that very easily, and that can cause for quite a few deaths. Some of the respiratory diseases that are common in the elderly would be something like chronic bronchitis, chronic obstructive pulmonary disease, having a neoplasia in the lungs. Any type of lung infection, tuberculosis and pneumonia can really wreak havoc in the elderly as well. Then we have cardiovascular and lipid changes. Think of how many older adults that you know and how many are on cholesterol lowering medications called statins, or some type of blood pressure lowering medication. I call them the toprolols. There's metoprolol, there's a whole ton of them. They seem to all end in LOL. I'm not a pharmacist, so I can't tell you the names of all of them. But it's a very important cause of death in old age, especially atherosclerosis. Eating a poor diet over time, and I say sugar is a bigger cause of this than fat itself, is usually a major cause of death. When somebody has atherosclerosis, it can cause high blood pressure, hemorrhages, thrombosis, stroke, coronary heart disease, and with age that increases. There's more risk factors. Age, as you're older, your gender, male, tend to be more prevalent. A genetic predisposition. My husband's family has a lot of heart issues. Obesity obviously is a big problem. Having high blood pressure, poor fitness, having diabetes, smoking, and having high cholesterol. So with this, HDL, LDL, and total cholesterol along with triglycerides increase as a part of aging. Now I want to change this up a little bit. HDL will decrease, the others will increase. Enzyme changes, we see these change quite a bit. There's no age-related pattern, but we do see them increase as people get older, especially the ones that you see listed here. AST, ALT, ALP, GGT, CK, lactate dehydrogenase, and amylase. So we do see those increase slightly. Now obviously a gross abnormal change, like an AST and ALT up into the thousands, that could mean hepatitis. But when we're talking enzymes that change, they increase a little bit out of the normal range that we see in the majority of people. But if they do have a disease process going on, they're usually a lot, elevated a lot higher than just a tiny bit. So here's what we're going to see. I think you're going to see more of it in the next 10 years or so as our baby boomers get older. We might start seeing more reference ranges for the elderly. Right now we see a lot of them for children under age 5 or under age 10, but we don't see a lot of them for people over age 65. So I think that as our population gets older, we might start seeing different reference ranges for people as they get older. Therefore, the physicians are probably going to get tired of seeing every elderly patient that comes through with abnormal test results. So they're going to want to see a chart that's got more ranges that say normal. Pre-analytical variables with the elderly. This is what happens before the specimen hits the lab, such as the blood drawing process or what the patient has done ahead of time. Different variables that can affect your specimens are the diet that they've eaten, the gender, and posture normally isn't much of an issue, but a lot of the elderly, depending on how old they are in a laying down position a lot of the time, and that can affect some of our lab results. Smoking can affect your ammonia results. Drinking alcohol, having a body composition that's varies from one person to the other, how much physical activity they're doing. The elderly tend to do a lot less, and what medications they're on. Many of them are on medications that could affect a lot of these test results. Think about some of these. I don't know how many of you out there are phlebotomists, but I know I've drawn quite a few elderly patients, and it can be a challenge. I think that hemolysis is quite common, especially when you get some of those veins. It looks like a big vein, you poke it, nothing comes out of it. It's kind of just an old sclerosed vein that just doesn't work very well anymore. So that's a problem. Sometimes they're dehydrated. So it's just so hard to get a blood specimen from them. Their muscle tone isn't there, so you're chasing those veins across their arm. Skin elasticity, I have seen people with, you put band-aids on their arm, you peel the band-aid off and your skin just rips. It's really sad. So we have to be very careful with specimen collection in these patients. Their skin is so sensitive. Sometimes using some paper tape or even some Coban that doesn't stick to the skin, only sticks to itself, is a good idea in these patients so that you're avoiding having those issues, especially if they're getting their blood drawn several times a day. I talked about therapeutic drug monitoring, so I'm not going to go into that in detail. But as you know, their organs aren't working as well to clear these drugs, so therapeutic drug monitoring becomes very important. Exercise and nutrition is imperative. I talked about the weight-bearing activity and just even walking as much as possible. Think about, I think of my step sister-in-law's grandparents. They call them Grandma and Grandpa Farmer, and they're in their 80s and they still farm. So these guys are out driving tractors. I think Grandpa just had to stop driving a tractor because of his eyesight. But otherwise, man, this guy does not sit still. Grandma Farmer, I think their last name is really long. It's like one of those Polish names that's got like a million letters in it. So the kids call him Grandma and Grandpa Farmer. But they don't sit still. Grandma Farmer is running around all over the place every time. I've seen her a few times. They're out at the farm. They're cleaning weeds out of their garden. They don't sit still. Having that type of lifestyle in an elderly person improves the overall health and cerebral function, increases social contacts, keeps them happier, reduces cardiovascular risk. They're not overweight. They've got more functional capacity. They probably sleep really well. Obviously, I've never asked them. But if once you stop moving, I think that you're done. You need to keep moving to stay healthy. So once grandma falls and breaks a hip and it's really painful, that's when I sometimes see things start to go downhill. They just don't want to move anymore because it hurts too much, and then their health can start to decline. So exercise and weight-bearing activity is so important. Oh, here we go. So now we get to move on to the pediatric patients. I have a bunch of my kids' pictures in here just for fun, so you'll get to see what some of my kids look like too if you're ever curious. So this in the bottom left-hand corner is my baby Caitlin. Obviously she doesn't have any clothes on. To this day, she still has a lot of rolls and she doesn't like to wear any clothes. Developmental changes from the neonate to the adult. So we're talking babies here. What happens with the respiratory and circulation? When they're in the womb, obviously they're in a bunch of liquid, so they require the oxygenation of their blood from the mom. Once they're born, pulmonary blood flow increases, blood pressure decreases at birth, the ductus arteriosus closes, and then the hemoglobin F, which you've learned about in hematology, is taken over by adult hemoglobin. Newborns usually gain about 6 grams per day once feeding is initiated. The weight doubles in 4 to 6 months. We see the organs usually are not fully developed, especially the liver, and we talked about this in our liver chapter. They're missing that enzyme that converts the bilirubin from unconjugated to conjugated. So it takes a little while, sometimes a week or so, for the liver to catch up, which is why they're kind of, some babies are yellowish when they're born, and after about a week or so, the liver kicks in and can handle it themselves. Sometimes there's problems with maturity and immaturity. We can see respiratory distress, we can see electrolyte and water imbalance, and sometimes jaundice there as well. Here's my son Justin with a blue tongue. Phlebotomy is sometimes a tricky with pediatric patients. All of my students are always so freaked out to draw kids, and I don't blame them. You may not even ever draw a child until you are at your, till you get your first job. When I did my clinicals at St. Vincent Hospital, so I had to go up to the NICU every single morning and get blood from those babies. That was kind of challenging. So I had a little bit of, exposure to them. Now my student Rachel that graduated, she never drew a pediatric patient. Now she works in pediatric laboratory. So all she does is draw kids all the time. So it doesn't matter if you don't have a lot of exposure. I think personally they're easier than drawing adults because their arms are tiny and their veins are huge. So I think the biggest challenge is talking them into sitting still. But we can only draw smaller amounts of blood. You can only draw their weight in kilograms times 2. That's how many mils you can draw in a day. So we have to be careful, especially little neonatal babies. You can't be going up there drawing a cc of blood every couple hours. We really need to be careful in how much we're taking. And you're going to have to know that calculation. Allowable volume is weight in kilograms times 2. Small veins need small needles, so there's a risk of hemolysis and having a lot of potassium from that. And we tend to use more capillary samples in children. Heel sticks are tough. We do them in little babies. Once they get to a point where, I'd say about 6 months, when they get the I call them the marshmallow legs, they're puffy. Their feet kind of turn more white than pink, and it's hard to get a good sample from them because they've got more interstitial fluid in their foot. Some of the pre-analytical concerns, we use pediatric sample tubes, so they're teensy tiny. You really have to be careful and make sure that when the cap comes off, you put the cap right back on to make sure evaporation doesn't happen in that sample. We want to be careful if you have an ICU unit in your hospital, if you do go buy a new analyzer or part of that acquisition process, that the analyzer can handle those small volumes. Sometimes the size of the probes and things like that really are a factor. You want to make sure that it can get down and get a very small amount of sample very easily. There's my baby Kate up in the top left-hand corner. By the way, she is 4 at the time I'm doing this recording, but she was probably about 1 in that picture. Or not even, probably about 9 months. Point of care testing is bigger in pediatrics, especially when especially when we do the NICU babies. Some of those point of care devices use 10 microliters of blood. Well, that saves an NICU baby a lot. Okay, so it's nice to have that. Plus the physician can get the results back right away. So that is something that might be helpful. We have regulation of blood gases and pH in the neonates and infants, which becomes important. I have a picture of my son Justin down here. He has a heart defect called Wolff-Parkinson White, and we had a lot of issues where he would turn blue and his oxygen levels would go down. This is just a picture of him being monitored. So the prematurity and lung development, when babies are born, there's a surfactant in the lungs, hopefully, if they're mature enough, which allows blood gases to exchange through after delivery. If they don't have that surfactant, the lungs kind of stick together, and it makes it very difficult for the lungs to breathe. If they know a mom is going into labor and they're trying to stop it, sometimes they can give them a shot of surfactant to increase that in the baby's lungs, so when they're born they have a better chance of being able to breathe. One test I have listed here, fetal fibronectin. We used to do this at the Bellin Hospital that I worked at here in Green Bay. It's a test done on the cervical mucus of the mom, and it can give them a prediction value of whether the mom may be delivering in the next few days. I don't know how perfect it is, but that was one of the tests that we did. Blood gas measurements, we do a lot of, on the preemies, we do a lot of blood gases to make sure that they're getting the oxygen that they need. So you want to have a good blood gas analyzer that can handle those teensy amounts. We usually get them from a heel stick. Or if they're really premature, they have an umbilical line, which has an arterial line coming right out of the umbilical cord. Kidneys, babies can become dehydrated and stuff very easily. And also the glomeruli and renal tubules don't function at a normal rate right away. It takes a while for them to catch up. So we do see sometimes a hypernatremia, hyponatremia, hyperkalemia, or hypokalemia, things that's challenging to keep those regulated, especially in a preemie. Jaundice, okay, we talked about this, the inability to convert that unconjugated over to the conjugated liver, or conjugated bilirubin, sorry, the liver has a hard time doing that. We see serum bilirubin levels of up to 15 milligrams per deciliter, which could cause kernicterus or brain damage. So that's when they put the baby under the billy lights to try and break down some of those things. I have a picture of my daughter and my daughter's friend who dressed up my son Justin in a dress and thought it was really funny. Energy metabolism is important. Babies have a hard time converting galactose to glucose. I see so many samples come to the lab on newborn babies, even in the regular nursery, and their glucose is usually really low. and they're having a hard time waking baby up. Baby won't feed. Mom's upset, like I need to feed my baby. My milk is coming in, all that kind of stuff. So sometimes they can just give a little bit of glucose to the baby on the tongue and the mouth, and it kind of perks them up pretty quickly. It doesn't take long for that to convert over and for the baby to be able to do that. It's quite common, actually. Here's a picture of my baby Kate in a stock pot. There's no way I could even come close to putting her in that now. But diabetes is a condition in which the endocrine control of glucose metabolism is abnormal. We talked about that, type 1 versus type 2. Type 1 is more common in the pediatrics. Another thing that we see is an immaturity of urea cycle enzymes and portal circulation. So we can see higher ammonia levels sometimes. Notice I have that highlighted in red. That usually means you need to know it. More liver function, creatinine. The levels are usually lower in a newborn. Their kidneys are just filtering things a lot quicker, I think. And concentrations increase with muscle mass. So as they get more muscle, you're going to see more creatinine. Liver function tests may be a little bit lower. And just a reminder here, Rye's syndrome is from aspirin in children, and it can cause a fatty liver. So don't forget that. That baby Kate here in the bottom again. As we get older, there's rapid bone growth. That's where we see the increased alkaline phosphatase. And we have more hormonal things starting to increase. We see higher calcium levels sometimes as well. But it's not that common. Hormone secretions, they're usually start to be produced, and we see more of it in puberty, as you would know, but we do expect to have normal thyroid function and adrenal function. The thyroid, if somebody does have, I'll just add this issue here, if somebody does have hypothyroidism in a pediatric setting, it could cause the stunting of growth. Okay, so that is something that needs to be watched. If someone is not growing at a normal rate, they want to check the thyroid to make sure that that isn't the cause. And if you do have a hypothalamic pituitary adrenal cortex system issue, there could be other issues as well. But these are things that I don't expect you to memorize at this point. If they have a deficiency, they would have the same issues that an adult would have. Oops, sorry. Next one, growth factors. We should have normal growth hormone, and we should have normal growth hormone inhibiting hormone. So we want to make sure that they're growing at a normal rate. We also, sexual maturation becomes important. We want to have normal amounts of gonadotropin releasing hormone, which causes the release of FSH and LH as they get a little older. Some things with the immune system. The innate versus adaptive immune systems are important. You're going to probably have me for immunology next quarter, maybe. And the innate immune system is the first line of defense that you're born with. After you're born, your body starts to adapt to things it's exposed to, which is called the adaptive immune system. This generates a specific reaction after exposure to different infectious agents. So I don't know if when I was little this is how it worked, but now there's a vaccine. If we had the chicken pox, our parents would bring us over to our friend's house and make us all kiss and hug and smooch, and that way you would be exposed to the chicken pox, and it was better to get it when you were 2 than if you're older. So that is something that we don't do so much anymore because there's a vaccine for it, but that is an example of adaptive immune system. You get exposure to it and then you're immune to it. Some other components of the immune system that are important: the skin, that's the first line of defense. We have phagocytes, or neutrophils, as you may call them, that engulf and digest foreign particles. We have B cells that make antibodies, natural killer cells that can just go ahead and attack a virus-infected cell. We can have acute phase proteins, which are defense proteins produced in response to an infection, and antibody production. So we need to make sure that we can make the immunoglobulins to fight off infection. The most common immunoglobulin in infants is IgM. IgG is then made later on. Mostly IgM, like I said, is present at birth. Obviously, you need to know that. The fetus can synthesize small amounts of IgG, and it's delivered through the fetus through the placenta or breast milk. So that's why they say breastfeeding is so important. Some of the immunology diseases that we see Transient hypogammaglobulinemia, which is just not having many globulins right away. It's transient, means it's going to pass and you'll end up developing more. Agammaglobulinemia is having no globulins, such as Bruton's disease. Okay, that's kind of like your boy in the bubble. Severe combined immunodeficiency syndrome is having very little functioning immune system, but having none would be more of your Bruton's. We do have some inheritance patterns that can cause issues with genetic diseases. You can have autosomal recessive, just recessive, dominant, or just a DNA that's inherited through the mother. Cystic fibrosis is another genetic disease. This one we talked about a little bit, but we see mutations in the cystic fibrosis gene, and usually the babies will find a pancreatic insufficiency. They'll have some type of a GI disorder before they find it, but that is autosomal recessive, and they end up with the excess mucus, etc. So one of the other things that happens when they're born is they get a newborn screening test done. I'm sure that you've had to look this up. I think we talked about it at the beginning of Chemistry 1. And some of the things that we screen for is phenylketonuria, that's important, a 21-hydroxylase deficiency, sickle cell disease, hypothyroidism, galactosemia. There's a whole big list of them. And we use tandem mass spectrometry to check multiple things at a time on every baby that's born. Each state has their own recommendations on that. We can have metabolic diseases. We can have large molecule and small molecule diseases. I'm not going to go into detail on those, but there are different types of metabolic issues. Excuse me. We have drug metabolism issues. So just like the elderly, we talked about therapeutic drug monitoring. In babies, it's the same thing. Absorption is important. How are they getting their medications? They usually get them in a syrup form rather than a tablet form, so it's absorbed differently. They have less fat tissue, so lipid-soluble drugs act differently. And their metabolic clearance, their livers are not very mature, so they have a harder time clearing those. So therapeutic drug monitoring becomes a little bit different in the infants and elderly than it does in just middle-aged adults. The toxicologic issues in pediatrics, they have to be careful with the ingestion of things. It's hard sometimes when a child may ingest something and you don't know what it is. So that's why they say you have to keep the drugs in a locked cabinet, or they have the what do you call those containers that you, childproof containers. So that concludes the section on geriatrics and pediatrics. Make sure that you go through, I did go through some of it quickly. A lot of it are things that have been covered in other chapters, so I covered it quickly, but I did go over everything that you do need to know for your Week 10 exam.